Before we do end the lecture, is any questions, any inquiry, any rights? Okay, in regards to the question, that you guys wanted to know if given credit or what have you. I talked to Professor Boone and I looked it up again in your book, yes, it does say red, does it say beefy or does it say smooth? Red beefy. I'm talking with regards to the question that asks about, conditions in the and it says the answer that was referred is paresthesia. Who had a question about that? There was branding. Okay, so basically, I can't nullify that one because when we present something to you, it may be in the book, but which is most detrimental to that question? That's not what the question asked. But we emphasize that, and it distinctly, paresthesia distinctly differentiates the folic acid deficiency, and also there's a difference between B12. Because there's other reasons why a patient would have a red cup. But paresthesia, no, I thought more of you have that issue. Okay, good. My exhibit A is here for respiratory. This lecture is generally presented by Professor Bethune. Matter of fact, she produced this, but remember our lectures are all interactive. We try to engage you. But when I get to upper respiratory, she's going to be exhibit A. But let's talk about some terms that you'll hear. Atelectasis you should have heard before. Where did you hear it? Last semester?
Yeah.
What were you talking about? What was the lecture?
She had a rocket and she was running.
Oxygenation.
It generally has to do with post-op patients, or there's some correlation. But atelectasis, collapse of alveoli caused by hypoventilation, obstruction to the airways, or compression. What post-op would predispose the patient to get atelectasis? CAD. Anesthesia, which would possibly decrease respiration. And if that patient's in pain, there may be some hypoventilation. History of smoking prior. What did you say, Angela? Correct. Anesthesia. Okay. All of those. And the fact that when you have hypoventilation, what happens, your secretions that settle, just settle in a certain area. And when you breathe, it kind of like helps move those secretions. When you cough, that's why post-op, you have the patient turn, you have them deep breathe, and cough. What else did you use with these patients? Spirometry. Yeah. Incentive spirometry. Incentive spirometry. How did you teach the patient to use it? Did they blow into it? No. What did they do? You're on it. Say it.
Deep breath and they didn't want to do it.
Take a deep breath, and then you want them to inflate those lungs by their breathing in when they're using that incentive to expand the lungs. We know they're expanding the lungs because when you take serial x-rays, there's no degree of collapse. And you notice that the patient doesn't have symptoms of hypoxia. Because if you're hypoventilating, you're not going to get that oxygenation. And what you're going to see in your patient is all of those things we saw when there's not enough oxygen circulating. Central cyanosis. Remember, cyanosis is always a late sign. Okay? Central cyanosis, bluish discoloration of the skin and mucous membranes. Here again, it's a late sign, but what might you notice about that patient beforehand? All of those things we have talked about in relation to hypoxia. And you know postoperatively to aid us in our assessment as to why a patient, if a patient is truly hypoxic, is we do those things like have the pulse ox there. Other things that you do is you actually assess the skin temperature. You look to see cap refill, all of the circulatory type of things. A lot of times, central cyanosis, where I've seen it, you'll see it with all people, but when you work with neonates, and you'll have that next semester, they have that central cyanosis. Matter of fact, we have a mannequin that demonstrates central cyanosis. And it generally starts here, but it goes systemic. Okay. So, we already said what we do for atelectasis. If you notice that a person has a degree of cyanosis and they're symptomatic with it, what besides the pulse ox would you obtain? What would you anticipate the physician ordering? ABGs. You want to know that O2 saturation truly at the arterial level, because the arteries carry your oxygenated blood. So that would be one. So you can expect if a patient is having any changes in oxygenation and it is late sign, there probably will be an ABG. On your ABG, what's in the ABG besides oxygen? Carbon dioxide, and it gives your acid base. Whether it's metabolic or respiratory, be it acidosis or alkalosis. Now, we're not going to be determining if someone's at this level, whether or not someone is metabolic versus respiratory. That is encompassing a lot of things in fourth block. You may have hit upon it in block 1, but that's not our purpose here today. Consolidation, pathological alteration of lung tissue from a aerated condition to one of solid consistency. That can be as basically you're working long-term care and someone's eating breakfast and they cannot control their secretions or anything they take in their mouth. And you do all those perimeter things like sit them upright. You give them small portions. You make sure that if they can't swallow as well, you use thicket. Any of you use thicket before? You use thicket. Because you don't want them to aspirate. Small portions of feeding from the spoon, sitting them upright, giving them space between bites or spoons that you give to them, giving them liquids, because if you're just getting them up, you want to give them liquids, but it needs to be with thicket if there's a dysphagia, which is swallowing problem. And you want to determine that they do not aspirate. Now, I've seen patients who have aspirated things from oatmeal to eggs, to liquids, and all of them at the same time. At first, what the person will manifest is they're coughing, trying to bring that foreign body up. If you do not see them coughing because they may not have a gag reflex or it's diminished in its effect, than a gag reflex, what you might notice within 24 hours, they're constantly wanting to cough. Within that 24 hours, maybe even 48, they may begin to have a fever. And with elderly patients, what might you see relative to mentation? Confusion. Infective process with elderly will manifest into confusion. Because they're not getting that oxygenation because there's a foreign body in the lung tissue. What might it look like on X-ray? Let's say this person aspirated on, let's say it was grits. I'm labeling my culture. Like, anyway, okay, grits, and they aspirated on it. What can happen is it can go in either lung, and you look on it on an X-ray, and that's a foreign body in that area. So if you look, say it happened on the left side, you look at the right, this is expanding. This side may be expanding, but not at the diameter of expansion as the other, because there's a foreign body taking the place of where there's the air exchange. So consolidation, it can be liquid in the form of something they drank. It can be blood. It can be food. And it can be just mucus. Words, dysphagia. Dysphagia, if someone has a problem swallowing, they're highest risk for aspiration. That's why when we have our patients like who have a CVA or have a neural involvement or that they do not have the intensity to swallow like myasthenia gravis, we'll get to these disorders. You don't have to remember. But these are disorders that affect swallowing. So, what can you do? A lot of times what they do in the hospital setting is someone will put in a consult because this person has a disorder where they're having difficulty swallowing, or they're constantly trying to clear their throat. And then you can notice also that this person drools. So they'll put in a consult with the speech therapist, because your speech therapist not only deal with speech and speech impediments, they deal with swallowing evaluation. And this is just overview of some terms before we get into some of the disorders. Hemoptysis, coughing up blood. What disorder comes to mind right away? TB. We're going to be talking about TB. But there are sometimes that people cough up blood and they may have varices. Those are dilated veins within the, it can be the esophagus, and the person aspirates that blood, and it goes down the trachea. It can be the trachea due to trauma, and the person is trying to cough up that blood. But it's generally associated, if it's episodic, and the person has other symptoms along with it, that it's usually associated with TB. If someone was coughing up blood, and you are the nurse on the unit, and it's something new to that patient, you can expect for that person to have some type of diagnostic. If possible, they may do upper endo. They may do an X-ray. They may do a scan. I'm going to stop right here a moment and let's talk about some diagnostics. We already talked about that. Relative to respiratory, there's a basic chest X-ray. Okay? If it is something relative to the trachea, they may have a endoscopic where they look at the bronchus. Okay. There may be, if there's a foreign body, there may be a biopsy obtained upon upper endo. If it is a CAT scan, you know the parameters. If it's going to be with contrast dye, what are you going to do pre-operative? Assess for allergies. What do you anticipate doing post-operatively? If anything is endoscopic, you want to make sure that you assess a gag reflex prior to the procedure, because you're going to need to assess for a gag reflex after the procedure if it's in the upper endoscopic. How would you know someone had a gag reflex? What would you use? It can be a sterile, not sterile, they're not sterile. It can be a tongue blade that you just put at the back of the tongue and elicit a gag reflex. Why do we want to elicit a gag reflex? Because we don't want this person who may not have a gag reflex or a diminished gag reflex to then be a candidate for aspiration. Other testing, biopsies, as I stated, they're looking for doing a cytology of the tissue obtained, and they're looking for maybe malignancies. What do I mean if I say malignancy? If there's some type of cancer, and they're looking at the cells as to determine not only cancer, but also what is the degenerative changes that you see there that might be atypical, not necessarily. Other things that may be done with your patients, let's say someone had a collapsed lung, they may have a chest tube put in. Any of you work with chest tubes? Any of you have a chest tube? Okay, a chest tube. And I'll make a point on Thursday to probably show you what a chest tube is. A chest tube is utilized when someone has a respiratory condition where there's a collapsed lung. And the collapsed lung can be from tissue that is ruptured within the lung tissue. It can be as a result of someone trying to put a central IV line in and nick the lung. It can be as a result of major trauma, where that your respiratory system usually goes by negative pressure for you to breathe. What happens is when there's a collapsed lung, you have these shallow respirations. Incentive to breathe is not there, it's flat. So they put in a chest tube, the physician will put in a chest tube, and there'll be serial x-rays through time to determine if that lung's reinflated. That chest tube is connected to a closed system to help get back that negative pressure that was lost. What you need to know at this level is that it is a sterile environment. That chest tube is never impeded or clamped where there's not where you see the tidling of the fluid. Also know that a chest tube, the main thing is to bring back where the person has the incentive to breathe and expand those lungs. There are some individuals who have a chest tube that is a closed system, but it's just a little flutter valve. But I'm just telling you guys that anytime there's where the lung is collapsed, the chest tube may be open. You'll get more into this in 4th block. Okay, orthopnic. What people have you seen in clinical that are orthopnic? COPD. And what is the degree of orthopnic? What do they usually lean on or at least do? They want to lean on. Generally, if someone is truly orthopnic, they need to be upright, and if it's a COPD patient, which we'll talk about, they kind of lean on the table or a surface, trying to get that volume of expansion. But really their problem, and we'll talk about that, is at the alveolar level. So they're trying their hardest to get that air that is in to come out when they sit up like that. Who have we talked about in the prior lectures that might be orthotic? CHF. Because there's a foreign body, which is all that fluid and mucus taking the place of the air exchange. Thoracentesis is, say someone has an inflammatory response or an infective process of tissue, the tissue is inflamed, and they put a tube in, and they can do it at bedside, but a lot of times they take them to interventional radiology, and via guided imagery, the image is on the screen. They introduce the needle and aspirate fluid. What do you think they're assessing that fluid for? They do a culture and sensitivity of the fluid. They look at it and visualize to see what type of color it may be. Prior to this procedure, though, of a thoracentesis, it is an invasive procedure, so you need a consent. That is your role as a nurse in conjunction with the physician. The physician needs to alert the patient as to what they're doing. You're just witnessing the situation. With these individuals, after a thoracentesis, there may be pain in the area, says the right side. What might you think the position of that patient be? If they're out in pain, let's see. Okay, you want the head of the bed up, but the patient's laying on that side. It helps diminish that sensation. And what you're watching for is the insertion site for any type of increased drainage or increased pain relative to the patient. Okay, now we're getting into upper respiratory infections. It affects not only the nasal area, but the ethmoid areas, frontal, maxillary, xiphoid sinuses, as well as the tracheal larynx. Some of us have had this throughout the semester, up to now. Okay, 90% of upper respiratory infections are caused by a virus. But it can also, 90%, the other 10 can be from, of course, bacteria or fungal. If the cause is virus, antibiotics are not going to help you because it's not a bacterial agent. So let me throw you out a question. Patient comes to you, to your unit, and states to you that, why are they giving me just this med for a virus? I'm in here, I have a low-grade fever, and I'm doing what I'm supposed to do, and do I have a virus? And their white count is normal, but they have a little low-grade temperature. Your rationale is to say your upper respiratory infection is related to a viral condition. Antiviral medications, those that decrease the viral effect, are given. Antibiotics will not take care of the viral manifestation. It may take care of an opportunistic infection that comes in. You need to explain to them is opportunistic means something on top of the viral that occurs. And you guys can know this too because with this influenza going on, people have gotten the injection, but yet they get sick too because there's different strains of viruses and bacteria that occur. And with viral infections, they're treated with relative to the symptomology. If it's a cough, if it's any type of drainage or congestion, we treat the individual causes. Okay. There is viral rhinitis, common cold. So you can look all important, go home with someone that has a cold and say, oh, you have viral rhinitis. Okay, acute sinusitis, chronic, and also acute pharyngitis, chronic pharyngitis, tonsillitis, and you'll talk more about that with teeth and adenitis, peritonsillar abscess, and laryngitis. With this slide, I'm going to stop a moment, and I'm going to have Professor McGill come forward. She happens to be one who manifests a lot of upper respiratory. So we will have her come up and we'll ask some questions. She'll give you a little history about herself, but then you need to ask questions. And this goes for any upper respiratory infection. She's come to our clinic and she's going to be Exhibit A for you to learn about her. I'm going to start now by, she came to your clinic and she came in, she's coughing, and she just looks all worn out. She's barely breathing. She's having, of course, she says she can't bring up any nasal uh, drainage or mucus. What's some pertinent questions you might? Well, let's let her give you a little history.
I have allergies. I've had allergies since I was a kid. Moving here, I thought would make my allergies better. No. I am really allergic to where I live, and I live in Maricopa. So, trying to figure out how to sell my house and write it off as a medical necessity, and I figure it out. I'll let you know. So, with that, I'll let you guys figure out what kind of questions you want to ask.
When did it start?
When did what start?
Your symptoms?
Before Christmas.
I see that you're living in Maricopa. Are you living close to any fields? Any particular fields that were
Anyone.
Well, I mean, like directly, like close. Like, say you're across the street from a cotton field, or
No, not across the street, but they're like all around me, but I don't know what was growing on the land at my house. Yes, ma'am.
Are you taking any current medication?
Oh, yeah.
What does that mean?
I take Zyrtec. What is Zyrtec? What kind of allergy med? An antihistamine, okay. I also take Singulair. Where have you heard Singulair from?
Asthma.
Asthma, but I do not have asthma. Singulair is called a leukotriene. Where have you heard leukotriene before? That's right, an inflammatory response. So in this case, the Singulair is going to help me with my allergies. So whatever inflammatory response to block those leukotrienes. I also take like 50 million nasal sprays. Flonase. What do you know about Flonase? Steroid. I also take Astelin. What was that? Astelin. It's a nasal spray. Have you heard of it before?
Mm-mm.
It's been on TV. Astelin is a nasal antihistamine. And then I also take Provolone.
Wow.
That's right. Wow.
You sound chronic.
It is chronic, but I have a few episodes. So this last episode started, and Provolone is also can be used for asthmatics, and it's an anti-inflammatory antihistamine. I don't know. When I first had sinus problems, I was back home, and one day at work, I was like, you know what? I haven't blown my nose in about a month. And they all turned and looked at me and was like, that's a problem. I was like, yeah, it is. So I went to go see a doctor. What doctor do you think I went to go see?
ENT.
Yes, I went to go see an ENT. What kind of test do you think she ran? A CT. What was she looking at? My sinuses. She said at that time there was some inflammation and some congestion, and she also said that I had a slightly deviated septum. So I don't know if that also causes some of my nasal congestion. But she just said keep doing what you do. Fine. So before Christmas or right around Christmas, what was floating all in the air?
Oh, they were harvesting cotton right about that time.
Cotton. What illness was starting to be really, really
Oh, the
prevalent?
flu.
The flu. So I don't know if I started with the sinus issues first or it morphed into the flu. But either way, I had two of them at the same time. So what do you think they do when you have a sinus infection? Antibiotics. What are some antibiotics you think?
Z-Pack.
Okay, I'm What else? Augmentin. What did you say?
Erythromycin.
Bactrim.
Levaquin.
Levaquin. Alright, you guys are pretty good. Let's see. Augmentin and Bactrim, erythromycin, all those things I'm allergic to. So that left me with Bactrim and Levaquin. What other medications can you give to help with inflammation?
Steroid.
That's steroids. So what steroid do you think I started on?
Prednisone.
Prednisone. Alright, so it's this thing called you can get a Medrol dose pack or you can do the prednisone. So he put me on prednisone. I first go around with Bactrim for 10 days and then a small little burst of prednisone. So 10 milligrams for 5 days or something like that. I don't know what it was. But it didn't work. After 7 days, I didn't feel any better. The inflammation didn't go down. So that kind of scared my primary because I've never failed an antibiotic before. So when you fail an antibiotic, what does that mean?
Resistant.
Okay. So then he moved me up to the Levaquin. But he was kind of hesitant to start me on that at first because there are strains of several different things that are becoming resistant to the quinolones, which Levaquin is that class of medication. So if I would have failed the Levaquin, then we really would have been in some murky waters. And then he gave me this crazy dose of prednisone, which is what someone who has a COPD exacerbation. So I counted like in 10 days, I had over 500 and something milligrams of prednisone. So how do you think I was feeling on that? Crazy. That's the best way to say it. I was irritable. Oh my God, I was hungry, like eating crazy combination of food at midnight. It was retarded. Yes.
So you said, look, you say you were resistant to that first drug. You're resistant to the second drug. What would happen? Because I know somebody who's admitted to the hospital had to be admitted they were resistant to two different or more like 2 different antibiotics for a UTI. So they admitted them, and I just don't get it. Why, like, I don't understand that. Because you're resistant to what?
If that would have happened, his next step, he said, we would have CT my sinuses and see exactly what was going on in there, and then refer me to an ENT, and probably I think I would have been hospitalized because they'd have to give me something to get that out of there. But that's why if it's a virus, you don't take what?
And
Antibiotics. You also don't share what? Your antibiotics. So because we got to the point where if it's a cold or if it's, the mucus color changes, it must be an infection, and people start taking antibiotics. Or what did my dad say? I've got some leftover antibiotics. I'm like, are you flipping kidding me? You don't do that. First of all, you don't know what you have. You don't even know if this antibiotic is going to work. And then if you get that antibiotic again, what's going to happen?
You're gonna
It's
build
not going to work because his body recognizes it. So that's why all these different strains of stuff are running around.
I'm always confused how they know if it's an infection or not, especially when you bring your child in to the pediatrician. They might just have a little grade 10 and say that's it, trying problems. I don't know how they can, without testing the culture.
Well, first he thought it was strep because my face was like ginormous. My jaws, I'm like, do I have some?
Like kids?
Like, yeah, it was like that. And the only reason I went to the diagnosis are really, really bad. So I knew I had trouble swallowing, but I couldn't figure out why. And I was like, are you choking? I was like, I don't know, no, because I'm talking. And so, and I was like, why can't I swallow? And I went like this, and literally all of my glands under here were just like swollen. You couldn't really tell. They made us do something, and I went to take my ID picture, and I looked at the picture, and I said, why does it look like I have a stroke? And I went to the bathroom, and this whole side of my face was like swollen, and I'm like, y'all supposed to be my friends and coworkers. You should tell me my face was swollen. What do you think I had pressure at? I couldn't chew. It hurt, and I love gum. I couldn't chew gum for like a month, which was really killing me because of all this pressure under here. And then what do you think happened with my ears?
Pressure.
Alright, so I had all that pressure and fluid in my ears. This ear is still, anyway. So that's when I went back to the doctor and he put me on all that stuff. So luckily for me, it got better. And something did happen with my hearing, but I'm not going back to the doctor. As long as I can hear, I'm fine. I don't want to see him for a long time.
Have you tried nasal irrigation?
Yes,
Oh, yes.
yes, I do.
Does it not help?
When it comes out, it helps. So I've been that congested where it will go in, and I'm like, okay, that needs to come out. I'm waiting, and I'm waiting. But I couldn't irrigate for a long time because I was so swollen, and I had all that fluid in my ear. I didn't want to blow my eardrum, and I didn't know how much fluid I had in my ear. So when I could finally breathe, and he knows my normal. So he's like, when you're, what did he describe it as? Raw hamburger meat? That's what he said the inside of my nose was like. He said it was totally, ugh. And he said he does not know how I can breathe. So what has my body done when I get that congested? I've compensated. So what do you think my husband hears at night when I go to sleep when I'm that congested? Yes. Lots and lots and lots of snoring. So irrigation, sometimes I have to do the saline spray if my nose gets really, really dry. One thing you guys did not ask me, I just told you I had allergies.
What are you allergic to?
Yes. Well, I didn't know I was allergic to cotton until I moved here. But I know I'm allergic to grass, so I can't walk in grass. Like if it touches my bare skin, then I itch. If someone freshly mows the lawn, that's how I get out of yard work, because I'm allergic to everything. I love flowers, but I couldn't even have fresh flowers at my wedding because it just wouldn't and all that. Dust, mold, pollen. I don't know, the list is growing.
You're like a bubble.
Just wear
So basically, what she had just said, what are some precipitating factors for someone to have these upper respiratory conditions? It can be seasonal changes. It can be, we live in a dust area. We don't know what's in that dust. Remember, she said she doesn't know what's in those fields. It can be irritants. What are some irritants that are relative to habits we have?
Allergies.
Habits.
Oh, habits. Smoking.
So, somebody said bleach. Bleach can, if it's a strong smell. My allergies are really bad. I love perfume. I love it, love it, love it. When my allergies are really, really bad, I can't do it because
What
it
about
messes with my
animals?
sinus.
Anybody say animals?
Animals, yes. I love Professor Deshler dearly, but I cannot go to her house because she has pets, and I'm allergic to cats. Anything that sheds, I can't hang out with them. And I want a doggy so bad. And all the dogs I want are hecka
Get one of
expensive.
those bear ones. The dog doesn't have hair on him.
That's
Or
ugly.
big
I know. I have to get a dog that doesn't shed, has no dander, and I want them little and cute and
Chihuahuas.
She mentioned all those irritants. So if you did a home eval of, you're the nurse, and you're doing a home eval of the person, and, in a scenario there's given that this person's environment is this, what is the correlation as to why that person is manifesting, say, some sinusitis? It would be those things, all the above. Animals, dust, people who are challenged with housekeeping, dust.
Don't judge. We're in nursing school.
Environmental stimulants that cause problems. Also, remember we said we treat symptoms. With rhinitis, you have the runny nose. What might be given? Something perpetrated. If it's running, it might, what did she say?
Something that dries it up.
Dry it up.
Antihistamine.
Antihistamine. But there are some side effects to antihistamines. If if she was taking antihistamine right today, and she's been on it, you check her pulse, what would it be?
Right.
Tachy. That's a normal side effect of antihistamine. Okay.
Benadryl, what does that make you do?
Tired.
Sleep. So, since it makes you sleep, what are some safety things you would have this person do? Don't drive.
Don't drink.
Okay. Huh? No what?
No, I
No
know.
alcohol in conjunction with. No alcohol in conjunction with. Okay.
Oh, a thing about Benadryl. Benadryl can also have an opposite effect. If it doesn't make you sleepy, it makes you
Hyper.
hyper. So if you have kids, you might want to test them out on a little bit before you figure out their response to Benadryl.
The one thing about acute sinusitis and chronic exhibit A, but there are some people who come in with acute sinusitis. Sometimes they don't even know they have a sinusitis problem until it's episodic. They go to a different locale and there's that irritant, that allergen that happens, and they go into acute sinusitis. Yes.
I heard from my auntie that a lot of chronic sinusitis isn't bacterial but fungal in nature, that they're just finding out, and that
Don't say that.
you don't think so?
I meant to don't say that because now I'm like,
That happens to my
Yeah.
I've thought about that. If I failed that second antibiotic, that's exactly where my thought
My
process
niece had to be
was.
hospitalized. She had acute sinusitis allergy since she was a child. She did a CAT scan. She had some sinus problems. They did an operation on her to fix some of her sinus inflammation and deviated septum and stuff. And he tested a culture at that time, and they found out it was fungal. And so after that, she had to go into the hospital when she healed, and she got the IV treatment. And she's been, probably been almost 2 years, I think, and she hasn't had an infection.
Remember, it can be viral, bacterial, or fungal. Now, with that being said, what would you need to obtain what would you need to obtain? A culture, a swabbing. Yeah, okay.
And you can have the acute pharyngitis from either from acute sinusitis or a cold. Why?
Goes down.
So that postnasal drip, right? It just kind of trickles down.
Do you get bronchitis
I have gotten it before
from the?
from that. Yeah.
Okay, and then tonsillitis, adenitis, adenoiditis. A lot of times, these days, the physicians are not removing the tonsils for a lot of symptoms, but if it's including airway consistently, those need to be removed. Adults, it's harder on adults when they have tonsils removed than children.
Very, very painful. Has anyone ever had their tonsils taken out? Or known anyone? The ice cream is just like, that doesn't even matter compared to the pain. The one thing, if anyone ever has the tonsillectomy or the adenoidectomy, you need to monitor them very close, their airway. And what will you be monitoring them for?
Bleeding.
Bleeding. How do you know that they are losing too much blood? Before that, what will they be doing? Coughing up blood or keep clearing their throat, or what might they say to you?
It's like blood.
Right, so they will have that, you can feel that running down back behind your throat. Yes.
My daughter had her adenoids out and she sounded like Fran Drescher for like 3 weeks and then it went away. Have you ever heard that? Like they get real nasally sounding? I called the doctor, I'm like, oh my god, is this gonna go away? Like, he's like, yes, it's normal. He said, it goes away in most people. I'm like, most people?
I want Fran Drescher as a daughter.
Yeah.
Well, my son, right now, my 3-year-old, he keeps like coughing and coughing. I've taken him to the doctor like 2 or 3 times already, and he said it was viral, and then they said just saline and Benadryl. But I've been doing that like constantly. He's not getting rid of it. Now it's coming up. Now there's little strains of blood in it. Should I go get him checked for tonsillitis now then? Because it's not going away.
you definitely need to follow up.
Yeah, because now
I
we
keep
have,
following up, but they just keep sending me home with nothing.
ask them to swallow. I mean, what's the harm in doing a culture? And having it come, I'd rather them do the culture and it's negative than poo-poo it and then he winds up in the hospital because they thought it was something else.
And then peritonsillar abscess, it's an airway type of thing, acute emergency. And laryngitis, your patient's going to not be able to enunciate. They try to enunciate, some can't even talk when they get laryngitis. Some people even wish they got laryngitis. But you know, the thing is, they can't talk because of the process going on and the inflammation that's going on. But let me throw you out a question that might be the thing. A patient says to you, everybody in my family is having the same symptoms. We're having an itchy throat, where our nose is running, and what would you need to know if they said everybody in their family? Huh?
Something irritant in their home.
There's irritant in their home, however, what I'm getting at is this. Children are usually the ones. School, they're in school, they're around everybody, they share everything, even drainage. Okay? So they're sharing that. They may not be as sick yet, but they're a carrier of the virus or the bacteria. They come home and hack and everything on you, spread that vapor, everybody else has. Okay.
There's this thing called you guys know about this, right? The prodromal period. Where prodromal, meaning before you can have symptoms but not know, or you're carrying it and you don't know that you have the virus or the illness yet. So I know with this flu thing going around, I want to say the prodromal period for the flu is anywhere 10 to 14 days. So you can have the virus, but you're symptomatic, but your body is doing what it's supposed to do to fight it off. And that's how come it spreads. Once one person gets it, it kind of spreads through wildfire through the household because everybody has been exposed to it longer than what they think they have.
And she mentioned a medication she takes, steroids. Steroids, a side effect of it decreases your immunity. So there are some people who look sicker, even though they're on, even though they're on a steroid-based anti-inflammatory, because it decreases your immune system, and you can get a new strain of viral or bacterial condition going on, or a new disorder altogether.
Another thing steroids can do, and I've heard some of you say this in clinical, it can raise your blood sugar, but it should not make it astronomically high, okay? So if your patient has a blood sugar of 300, and before it was like 120 or maybe even 200, it's not the steroid. I tell my students to go look in the room and tell me what you find. And then they come out and list all the things that this person should not be eating or what the family member has brought in to them. Yes.
I know sometimes on steroids it can make your face swell up, and I'm just wondering, does it cause higher blood pressure as well, or no? Just because you're swelling and certain, like they say that like moon phase.
That's something else. That has something to do with Cushing. If they develop it,
But
because
if you're
your
taking
kidneys
steroids, can't that cause that temporarily?
temporarily, yeah,
But that doesn't increase your blood pressure, no?
not necessarily. But the other side effects you need to know, like the irritability, the hunger, if it can increase your blood pressure and this person is not diabetic, where are your glucocorticosteroids made? Where in your body? Yes, your
Oh, the
adrenal glands. Where are your adrenal glands? Above your your kidneys. So you may want to start monitoring them for what?
Fun.
All right, so you want to look at that BUN and that creatinine, okay? And if they go into Cushing's syndrome, then you might want to start monitoring them for check up the glucose level to see if it's elevated. What are some signs and symptoms of diabetes? All right, so the increased thirst, the increased hunger, increased what?
Urination.
All right. Even though those things are side effects of prednisone or Medrol, whatever steroid they give you, you need to really educate your patient to look at, other things like increased tiredness. And if they have a family history of diabetes, then I would tell them to, check your blood sugar periodically while you're on this medication.
Okay, so the meds that we talked about was antihistamine, side effect for antihistamine. A type we talked about is Benadryl. We talked about steroids, and we just went over some side effects of that. We talked about, as in broadly speaking, antiviral as a group, anti-fungal, not so much, but antibacterial. What is your therapeutic goal to see relative to someone taking an antibiotic? What labs would you be? Your CBCs, where their white count. What will you be seeing in the patient if it's an antibacterial that systemically they're getting better? What will go away?
Cough.
Temperature, cough, okay. If it is an antiviral and they do another swabbing, that viral level should be going down.
Some of the same things that you can do for viral, can you not do for someone who has a bacterial infection? So what are some of those things that you can do? If they have a fever, you're going to give them what? Tylenol or ibuprofen. Everybody on this list needs to increase their what intake? Fluid intake. Can they not do the nasal irrigation or the saline spray? The neti pot. If your patient, what foods are good for these people? Protein.
Citrus. Vitamin C.
What did you say?
Vitamin C. Oh.
Vitamin C. Let's talk about your pharyngitis and laryngitis people. What should they stay away from? Dairy. Okay, so your dairy. Why?
Increases secretions.
Okay, increases mucus production. Things like mashed potatoes. You need to educate them to stay away from that. Why? What else? What are they made with? Starch. Doesn't have butter in it and doesn't have milk in it when you make mashed potatoes. Okay, so that's gonna increase that, and then it's starchy. What about liquids? What kind of liquids should they drink? Orange juice. What does orange juice have in it? Acid. How does acid feel on a
Burns.
raw? Ouch, right? So I knew I needed vitamin C, and I hate taking pills anyway. So it was a struggle for me to get through this whole process because I hate taking medicine. So I made myself drink orange juice, but I kind of diluted it a little bit with a white soda, and I did it at room temperature or with a few ice cubes, just so it would not burn the heck out of my throat. Go ahead.
In conjunction with that, orange juice is irritant. What types of foods in general would you have them? Any spicy, irritating foods. That tissue is already inflamed, and you're given it's not the time to go to Del Taco, El Taco, or anything like that, because it's just gonna cause more irritation.
No flaming hot Cheetos. No ice cold Mountain Dew that you want to slam. And no hot beverages. So like hot chocolate, hot tea, hot coffee. What happens when you put that on there?
burn.
it's gonna burn. So you want the cool or tepid temperature.
Let's break. We'll come back.